obesity in terms of drugs. We are hearing a lot about obesity drugs across the West and even now in India. And do we have, like how safe are they? What is your take on that?
So I think this is a great question. Obesity treatments, particularly medical treatments, have been crowded with controversy and have been clouded with a lot of misunderstandings and myths. Because the old drugs all operated on the appetite mechanism. They switched off the appetite, switched off the craving. And the initial drugs which came on, like fenfluramine or phentermines, and various other drugs which came in, sibutramines, the locarcerines, they all unfortunately had to be withdrawn because of adverse effects. And in the South America, there was a salivary secretion from a South American lizard, which created a peptide which is made in our intestine called incretins, the GLP-1 and the GIP-1, the K and the L cells of the intestine made them. We know beta cells make insulin, alpha cells make glucagon, and a peptide or a protein or a amino acid protein byproduct called GLP-1 is made by our intestine. These peptides in the intestine not only control glucose or diabetes, but they go in the brain and work on the hypothalamus to switch off the appetite and burn the fat. And these agents are available orally and injectably both. These are called GLP-1 agents, single agents, GLP-GIP-1 agents, double agents, and now there are triple agents also available, mainly manipulating or mimicking the actions of GLP-1, GIP, and the glucagon receptors. And these pharmaceutical and chemical scientists made discoveries. They switch off appetite and cause compelling weight loss. For a drug to cause weight loss, it should be more than 5%. But the GLP-1 agent, for example, what's available in India as oral semaglutide, can cause weight loss from 8 to 12%. We have a dual agent which is going to come in, which is called as tirzepatide, which will cause weight loss up to the 12, 14, 15, 18%. And then we are going to get a triple agent called the retatrutide, which will cause weight loss much more than that. And many such agents are getting available. These agents will cause some nausea and vomiting. They must be given under medical supervision. You have to slosh very slowly and go very gradually. They can occasionally impact the pancreas and cause pancreatitis. You need to give them under medical supervision. You need to avoid alcohol or conditions which make you predisposed to pancreatitis. But beyond that, you need medical supervision for these drugs. They should not be taken off label, and they are very popular. They are out of stock, and many of these agents have been available for some time now. So they have gone through a pharmacovigilance portal. Of course, if a drug will work, it will have effects and side effects. They are not only useful for reducing weight and burning fat or reducing the fat, but also are useful for diabetes. They are useful for MASH or metabolically associated fatty liver disease. They are useful for sleep apnea and many other conditions, including neurodegenerative disorders. So it is as Charles Dickens said, we are in best of times but worst of times. So these drugs are excellent molecules which are available. The current challenge is they are not accessible or affordable for the large mass of population, and therefore lifestyle remains supreme. Secondly, when we rapidly lose weight, we also lose some muscle mass. So you need to supplement it with protein. And before we give these drugs, medical supervision is very important. Mental health screening is very important. And ensuring that you don't have underlying any cancer history is very important. So giving them under medical supervision is very important. And therefore, these drugs are here to stay. And these drugs are actually competing with bariatric surgeons. Because in severe cases, in morbid obesities, even today, bariatric surgery is an excellent option. Because in bariatric surgery, we are able to get drastic weight loss in people who have BMIs about 35, 40, 45, 50. And we have long-term outcome results from bariatric surgery. If done under skilled supervision and skilled hands, bariatric surgery is still there. Having said that, even endoscopic procedures are being discovered. So as I told you that these drugs are available, these drugs need medical supervision, these drugs are expensive, so affordability and access is still a rate limiting step and should be given under strict surveillance of an endocrinologist or a qualified physician who knows how to handle these drugs better. And occasionally, a morbid obese case may need even a surgical intervention or an endoscopic intervention. So, as I said, obesity is a manageable disease, but we need a lot of counseling, a lot of positive happiness, and beyond that, we also need to ensure that lifestyle is integrated. We also have novel technologies. For example, we have this whole body digital twin technology. We are trying to reverse obesity through that. So there are many other things which are there in the domain, but these are in experimental domain. But the drugs which have come in are now here to stay. They are approved by FDAs, both US and Europe, and even the Indian Drug Controller General has given the nod for the oral semaglutide which is available. And soon, by the end of this year, we will have injectable uh, semaglutide as well as tirzepatide available to the Indian population. So I think it is a good option which will be available for people living with obesity, and it is particularly useful for those who have associated comorbidities like heart disease, hypertension, diabetes, heart failure, fatty liver disease. It will be very, very useful. Obstructive sleep apnea. So I think this is a great question. And as I said, these are good options, and we will be getting more and more of these options as we pass time. And when they become generic, then obviously more and more people will be able to access it because it will become more affordable. But they will still need medical supervision and they will still need pharmacovigilance.